So I'm going to be speaking on current strategies for adjuvant therapy, ongoing and future trial research, and this is in non-small cell lung cancer. I'm having issues advancing here. All right, so to start with the easy stuff, the current status of adjuvant chemotherapy in non-small cell lung cancer, it is indeed standard of care, but how did we get here? This was not always the case, in part because a multitude of earlier randomized studies did not show any benefit to adjuvant chemotherapy given after definitive surgery for non-small cell lung cancer. Although there were several limitations of these early studies, they used regimens that we now know, even in the advanced setting, have marginal activity. They included patients with compromised performance status and multiple comorbidities. There is considerable difficulty in administering systemic therapy to patients in the postoperative setting, and also some of these studies were inadequately powered and had overly ambitious survival endpoints. Nevertheless, when the earlier studies were combined and only the cisplatin-based chemotherapy regimens were looked at, there was a small benefit in a meta-analysis in terms of overall survival for patients getting chemotherapy after surgery versus those getting surgery alone. And this benefit was an absolute benefit of about 5% at 5 years. The YALT study was the first of the more modern adjuvant cisplatin-based chemotherapy trials after surgery, and it took all comers with surgically resected non-small cell lung cancer and randomly assigned them to either observation or cisplatin-based chemotherapy with a multitude of different regimens, including etoposide, vinorelbine, vinblastine, or vindicine, administered within 60 days after surgery. And this was the first study that did show a statistical benefit in terms of chemotherapy, though admittedly that was a modest benefit. There was a 4% improvement in overall survival at 5 years and a 5% improvement at 5-year disease-free survival and an improvement in the median survival and disease-free median survival. However, that was as it was initially presented. With additional follow-up, in fact, the hazard ratio is no longer statistically significant. The p-value is 0.1 with a hazard ratio of 0.91, and that is because after the initial 5 years, there seemed to be an increased risk of death in the patients who had received chemotherapy versus those who had not. The NCIC BR10 study was the adjuvant study, the modern adjuvant study that showed the largest magnitude of benefit for patients getting chemotherapy. 482 patients with completely resected 1B or stage 2 non-small cell lung cancer were randomly assigned to cisplatin or vinorelbine, with the cisplatin given split doses day 1 and day 8, and the vinorelbine given every single week, 25 milligrams per meter squared, versus no chemotherapy in the control group. This study, when initially presented, showed an absolute improvement in overall survival at 5 years of 15%, going from 54% to 69% in this patient population. And unlike the YALT study, the study has held up with additional follow-up, and now at 9+ years, the overall survival remains statistically significant in favor of chemotherapy, with an 11% benefit in overall survival at 5 years. There was an elderly subgroup analysis done of this study to see if those who were considered elderly with a breakpoint of 65 benefited from chemotherapy. Indeed, it was observed that these patients were less likely to receive chemotherapy overall. In this particular study, there was not a difference in toxicities for the elderly age group. For the patients over the age of 65, they did indeed benefit from adjuvant chemotherapy with a hazard ratio of 0.61 and a p-value of 0.04. If we break it, though, just into those over the age of 75, the benefit is less clear. This was a small patient group, only 23 patients, but the hazard ratio actually favored observation but did not achieve statistical significance, but came close with a p-value of 0.09. The CLGB 9633 study was another study looking at adjuvant chemotherapy, and this was unique in 2 ways. It looked only at patients with stage 1B disease, and was, as we'll be discussing, this is a particularly controversial group. And this is the only study to use a carboplatin-based regimen. Patients either were observed following surgical resection, or they received 4 cycles of adjuvant carboplatin and paclitaxel. And this was another study that initially looked good. When it was first presented at ASCO in 2004, there was a statistical benefit in terms of overall survival for patients getting chemotherapy. But with further follow-up just 2 years later, when represented at ASCO, the study had lost the statistical significance in terms of overall survival. Although it maintains a statistically significant improvement in terms of disease-free survival with a hazard ratio of 0.74 and a p-value of 0.03. So a lot of these modern cisplatin-based chemotherapy studies were put together in a meta-analysis called the LACE meta-analysis, stands for Lung Adjuvant Cisplatin Evaluation. 5 studies, including the YALT study and the BR10 study that I showed you, were included. 4,584 patients with a median follow-up of 5 years. The majority of patients were male. Median age was 59, and only 9% of the patients included in this meta-analysis were over the age of 70 years of age. Pathologic stage, only a small minority were stage 1A, 8%. 30% of patients had a pneumonectomy, which is a rather high pneumonectomy rate in a surgical series. The histology, about half the patients had squamous cell, which would probably not be true if we were to look at current studies of current patients getting surgery for lung cancer. In any case, this meta-analysis, looking at the 5 more modern studies, did show an absolute survival benefit for patients getting chemotherapy in terms of both overall survival and disease-free survival, with a 6.9% decrease in risk of lung cancer death at 5 years. But there was an increase in risk of non-lung cancer-related deaths for patients getting chemotherapy, with an increase of 1.4%. So chemotherapy is good for the lung cancer and not so good for the other things you have going on. So here are the forest plots of the LACE meta-analysis showing you the 5 different studies and the magnitude of the benefit. The hazard ratio 0.89 in favor of chemotherapy for overall survival, p-value 0.005, and for disease-free survival, hazard ratio 0.84, p-value less than 0.001. So this leads us to the current recommendations, and here's the list of the ASCO recommendations. For stage 1A disease, adjuvant chemotherapy is not recommended, and I'll go into why that is shortly. For stage 1B disease, adjuvant cisplatin-based chemotherapy is not recommended for routine use, so it allows for a little wiggle room there, but it is indeed recommended for stage 2A through 3A. And this holds up as well in the NCCN guidelines, where for stage 1A non-small cell lung cancer, observation is the recommended strategy after surgery. For stage 2 and 3A, clearly chemotherapy is recommended. But for stage 1B disease, those patients you can either observe or, as a category 2B recommendation, chemotherapy in high-risk patients would be reasonable to consider. So if we're talking about the controversies in adjuvant chemotherapy for lung cancer, which regimen should we use? Should we use cisplatin or should we use a carboplatin-based regimen? What about stage 1B disease? What do we do for these patients? Are there any predictive or prognostic biomarkers that can help us decide? And how about radiation after surgery for lung cancer? Is that something we should consider? So starting with which regimen, if we look back at the LACE meta-analysis, the plurality of patients, 41% actually got cisplatin and vinorelbine. It was the regimen used entirely in the ANITA and the JBR10 studies. And if you look at those patients getting cisplatin and vinorelbine versus those getting the other combinations, indeed there was a statistically significant advantage for the patients getting cisplatin in terms of overall vinorelbine in terms of overall survival as well as disease-free survival. So that came out as the leading regimen in the LACE meta-analysis. Now, part of this may be that the patients who got vinorelbine-based chemotherapy also happened to get more cisplatin. 86% of them got greater than 300 milligrams per meter squared of cisplatin. And if you look at the cisplatin doses, those patients who received more than 300 milligrams per meter squared had a trend improvement in overall survival as well as disease-free survival. So there does seem to be a dose intensity that is important for these patients. In addition, it's less clear that chemotherapy is effective in stage 1A patients, and only 13% of the stage 1A got the cisplatin vinorelbine treatment, whereas 43% of the other stages got this. So there were more patients with potentially chemotherapy responsive stages who actually got the cisplatin and vinorelbine chemotherapy. These are the chemotherapies used in the other studies. You can see that all of these are considered older chemotherapy regimens that we don't tend to use these days in the treatment of non-small cell lung cancer. So what about the more modern regimens? Well, we don't have a lot of adjuvant studies looking at those, at that data, but we can perhaps extrapolate from the advanced setting. This is a study that had compared cisplatin and docetaxel to cisplatin and vinorelbine, and in fact, in the advanced setting, showed that there was an improvement in terms of overall survival for those patients getting the taxane-based regimen. So this might mean that maybe cisplatin and vinorelbine is not the optimal regimen in the adjuvant setting. And then once you open it up to cisplatin and docetaxel, well, then we have the ECOG studies showing that any number of modern platinum-based regimens seem to be about the same as cisplatin and docetaxel. So really, can we take anything that we tend to use for metastatic non-small and extrapolate that to the adjuvant setting? What about cisplatin versus carboplatin? Well, again, this has been compared head-to-head only in the advanced setting, but this is a meta-analysis showing many studies looking at cisplatin versus carboplatin, and in terms of response rate, that favors cisplatin over carboplatin for these patients. And in the advanced setting, cisplatin regimens also have a strong trend in terms of improvement in overall survival versus carboplatin. So I do think it's reasonable to presume that cisplatin may be a superior regimen over carboplatin, and in patients who are eligible for cisplatin, that's what they should receive in the adjuvant setting. There is one study that was actually done specifically in the adjuvant setting trying to evaluate which regimen is optimal. This is the TREAT study, which was a randomized phase 2 study on refinement of early-stage non-small cell adjuvant chemotherapy with cisplatin and pemetrexed versus cisplatin and vinorelbine, which I just showed you is the leading regimen from the LACE meta-analysis. And the reason this study was taken on was because there are definite deficiencies with cisplatin and vinorelbine as a regimen. If we look in the JBR10 study, 50% of patients getting cisplatin and vinorelbine had incomplete treatment, meaning they were not able to finish 4 cycles. The reasons patients came off study was either 29% refused, 13% had significant toxicity. There were also significant delays in this chemotherapy, and 77% of patients getting this regimen required dose reductions. So the rationale for the TREAT study was perhaps cisplatin and pemetrexed would allow for higher dose intensity and lower toxicity. So this took the exact regimen used in the BR10 study, cisplatin vinorelbine with the split dose cisplatin and the weekly vinorelbine versus standard dose cisplatin pemetrexed, 75 milligrams per meter squared and 500 of the pemetrexed given once every 3 weeks. It was open to patients with stage 1B through 2B disease and selected 3As with T3 and 1, and they were treated within 42 days of surgery. They had to have an excellent performance status. The study was initiated in 2005, which is important because there was not as good understanding of pemetrexed only being efficacious in non-squamous cell at the time the study was designed. The primary endpoint was clinical feasibility, and it was considered promising if it was feasible in greater than 80% of patients. And by feasible, they meant there were no deaths due to cancer, toxicity, or comorbidity, no non-acceptance by patients leading to premature withdrawal, and no observation of dose-limiting toxicities. So these are the characteristics of the patients. The majority were male. The age was rather young at median age of about 60. And here's the stage breakdown given. So pneumonectomy rate, more what we expect to see, between 10 and 15%. And this is important to note for this study when we're going to be following it going forward, that about 40% of patients in both arms had squamous cell histology. And again, we know that this may not be the best histology for use of pemetrexed. So here we have the primary endpoint, and that is feasibility. In fact, the cisplatin and pemetrexed was considered feasible in 95.5% of patients compared to cisvinorelbine only in 75%. So a highly statistically significant difference. More patients in the vinorelbine arm were likely to withdraw consent, and there were more dose-limiting toxicities. And that was predominantly febrile neutropenia as well as neutropenia in the patients getting vinorelbine. As far as early termination of therapy, that was much more common in the vinorelbine group, where 63% of patients terminated therapy early compared to only 22% of patients in pemetrexed. The adverse events were significantly reduced in the pemetrexed arm, where fewer percentage of patients had grade 3-4 hematologic toxicity, about equivalent in terms of non-hematologic toxicity. And here are the curves for time to treatment failure, with time to treatment failure being defined as either progression, relapse, or death, failure to return to therapy, or refusal of treatment. So you can see that the pemetrexed arm did significantly better than the vinorelbine arm. So conclusions of the TREAT study: cisplatin and pemetrexed is a safe and feasible adjuvant therapy to give after surgery for non-small cell, less toxicity, superior dose delivery, and higher dose intensity than could be achieved with cisplatin and vinorelbine. The dose delivery breakdown in the vinorelbine arm arm was mostly due to an inability to get in those day 15 and 22 doses. For efficacy, longer follow-up is awaited, but this will be compromised by the fact that there were 40% squamous patients in the arms. So cisplatin and pemetrexed can be added to any of a number of other reasonable regimens for use in adjuvant non-small cell. These are the regimens that were used in ECOG 1505, which was a randomized study of 4 cycles of chemotherapy alone versus chemotherapy plus bevacizumab to determine which is the superior adjuvant regimen. The bevacizumab was continued every 3 weeks for a total of 12 months. This includes cisplatin and vinorelbine, but also cisplatin docetaxel, cisgem, and cispemetrexed was added later in the study. Here is the schema for this study, and it recently closed to accrual in September. This took patients with completely resected stage 1B through 3A, although it was revised to exclude 1B less than 4 centimeters. Squamous patients were allowed in this study because once the tumor is out, the concern for bevacizumab and hemoptysis in squamous patients is negated. And they are randomly assigned to 4 cycles of chemo or 4 cycles of chemo plus bevacizumab. And of course, this was based on the fact that if we're extrapolating from the advanced setting, that bevacizumab, when added to carboplatin Taxol chemotherapy in the stage 4 setting, did show improvements in terms of disease-free and overall survival. So now I'm going to get into what that controversy is with stage 1B disease. If we look at the LACE meta-analysis stratified by stage and see what the hazard ratios are, for patients with stage 1A disease, tumors less than 3 centimeters node negative, chemotherapy actually has a detrimental effect following surgery. So patients are more likely to die if they get chemotherapy, and that's what leads to the recommendation that you not give these patients adjuvant chemotherapy. Clearly, chemotherapy is beneficial for stage 2 and stage 3, but the 1B, there was not a statistically significant benefit to chemotherapy, but at least it didn't seem like it was harmful. So clearly, we should not be using chemotherapy for stage 1A patients, but the jury is still out for stage 1B. Here is just the breakdown by stage in some of the various studies, the YALT, BR10, and NEAT-NCLGB studies, which was only done in stage 1B disease, as well as the LACE meta-analysis. You see positive results for chemotherapy are only seen in stage 2 or 3A disease, and none of these studies were positive in stage 1B, although you could argue with the improved disease-free survival in the CALGB study that that would be indeterminate. However, if you do a subgroup analysis on these 1B patients and you use 4 centimeters as the breakpoint, which was done in both the BR10 study and the CALGB study, we actually see that chemotherapy does have a positive benefit in those tumors greater than or equal to 4 centimeters, but not those less than 4 centimeters. So one of the reasons for the wiggle rooms in the recommendation is that for patients who have 1B disease, but their tumors are greater than 4 centimeters, then adjuvant chemotherapy is reasonable to administer. Now, unfortunately, if you're one of those folks who is trying to memorize the new staging system by tumor size and what that means for your T stage, none of the breakpoints is 4 centimeters. So it's a completely different measurement that you're going to have to memorize. How about prognostic or predictive biomarkers? When we treat patients with chemotherapy following surgery, the majority of the patients aren't benefiting at all. They either are already cured from their surgery or not cured regardless of whether or not they get chemotherapy. So wouldn't it be great if we could pick which patients really need the chemotherapy and not just give it to everybody? Is there some prognostic marker we can use to predict those patients who are likely to relapse and only give chemotherapy to those patients? Or is there some predictive data to help us determine which treatment is most likely to be beneficial to which patient? Is this actually not working? You guys are just figuring out and advancing it for me? I'm not sure. I'll keep trying. Okay, so ERCC1 is one of those predictive and prognostic markers that look promising. It is a DNA repair enzyme that is felt to be important for resistance to cisplatin. It helps in the nucleotide excision repair pathway. So it is good to have the enzyme so you can repair your DNA unless you're getting cisplatin, in which case the way cisplatin works is by making it so that you can't make the repairs and leading to apoptosis. So in fact, in the YACHT study, when we looked at patients and whether or not they had ERCC1 positivity, just it would be predicted, the ERCC1 negative studies, the ones that could not repair their DNA, did better with chemotherapy than if they had not gotten chemotherapy. And this was not true of the patients with the ERCC1 positive tumors. So therefore, you could think that maybe we should just reserve chemotherapy for patients who have ERCC1 negative tumors, and we can get away from getting chemotherapy to everybody. There are several studies that have been done trying to look at different biomarkers, many using ERCC1, to choose which chemotherapy to give patients. If your ERCC1 is positive, then perhaps they should not get cisplatin-based chemotherapy, but some other form of chemotherapy. There have been difficulties with this, though, first and foremost being that the antibody, the 8F1 antibody used in the initial YACHT data set in 2006, no longer seems to be staining the way we would expect when it was redone in 2011. This is a correlation between the H-score for ERCC1 staining in 2006 versus in 2011, and we see a lot of folks who are in here who had a low score in 2006 but a high score in 2011. Not only that, but there are lots of different antibodies looking at ERCC1, and there are lots of different isoforms of ERCC1, and not all of them are active. And in fact, an evaluation of the 16 currently commercially available ERCC1 antibodies could not distinguish between the active and inactive ERCC1 isoforms. Okay, so this was actually part of what was presented in the TASTE study, which was presented at ASCO this past year. This was a feasibility study using biomarkers to determine what treatment patients should get, and treatment was based on EGFR mutation status as well as ERCC1 mutation status. EGFR mutants were seen in approximately 10% of the patient, or 7% of the patient population, about what you expect, and ERCC1 positivity was seen in 25% of the patients. So that's shown here. This was a study where their treatment was determined if they had an EGFR mutation, then they were going to be assigned to get erlotinib, but they would get cisplatin based on the ERCC1 status. Whoops, go back. And the difficulty with the study was, from the historically, what we would expect from the YACHT study, we would expect about 10% of patients have EGFR mutations, and that was true. However, this is the breakdown of what we would expect for the ERCC1 positive versus negative, and that was not seen. There was an underrepresentation of the ERCC1 positive patients, making the investigators question the accuracy, and as I just showed you, there was a rationale for that. The study was therefore stopped at 150 patients because of the aberrant behavior of the IHC staining for ERCC1. This is another study, the Spanish Customized Adjuvant Treatment Study, or the SCAT study, which uses biomarker selection for patients. Completely resected patients with nodal disease positive were either assigned to a control arm of cisplatin and docetaxel, or an experimental arm where they were treated based on their BRCA1 status. BRCA1 is involved in the mismatch repair pathway. High levels are supposed to sensitize patients to antimicrotubulin agents such as the taxanes, whereas high levels would inhibit apoptosis with platinum. So based on the quartile that these patients were observed, they would either get cisplatin-based chemotherapy without a taxane or taxane therapy alone. We do not have the results of this study yet, but at ASCO they presented a similar study that was done in the advanced non-small cell patient population, using the exact same mechanism of disease assignment, either the control arm versus chemotherapy based on biomarker status. And unfortunately, the patients in the experimental arm who were assigned their chemotherapy based on the biomarkers did worse than the patients in the control arm. Particularly worse were those patients who were in the docetaxel alone arm. They did not get the benefit of platinum-based chemotherapy because their BRCA1 status was such that they were expected not to benefit from platinum, and yet these patients did seem to miss out from not getting their platinum. The Southwest Oncology Group is also doing a study, a biomarker adjuvant study that uses RRM1 and ERCC1 for determining which patients are going to be just actively observed versus those patients who are going to get cisplatin and gemcitabine. And the ITACA study is a study using both ERCC1 and thymidylate synthase levels to determine which patients should be assigned to cisplatin-based chemotherapy versus those who should be getting pemetrexed based on the thymidylate level versus controlled chemotherapy, which is investigator choice platinum-based chemotherapy. So those studies are still ongoing. The CLGB also is doing a study that initially was designed to be biomarker driven, but given questions they had with their gene array profile, it no longer has that as an assignment strategy. Patients with stage 1 disease are assigned to either cisplatin-based chemotherapy or observation, and while it is no longer biomarker directed, nevertheless, collection of high-quality fresh frozen tissue for gene expression array generation is part of the primary outcome to try to determine if there are any gene expression profiles that can be either predictive or prognostic for patients benefiting from chemotherapy. Now, the SELECT trial is an ongoing study that looks specifically at the EGFR mutant patient population. Patients with completely resected non-small cell who are found to have EGFR mutations, either deletion 19 or L858R, are assigned to either chemotherapy or not, depending on the patient and treating physician preference. But once the chemotherapy is completed, they get adjuvant erlotinib for 2 years. And we do have results on the first 36 patients. The majority of these patients were female, and as might be expected, 56% were never smokers and 28% were distant smokers. Here's how the stages break down for these patients, and 61% had an exon 19 deletion and 36% had an L858R point mutation. Anticipated, or the toxicities were what one would expect from erlotinib: rash, diarrhea, and fatigue, as well as transaminitis, hyperbilirubinemia, and urticaria. And here's how we have the 36 patients. Anyone making it to this line are those patients who are able to finish all 2 years of therapy, and the color shows you what dose they needed. The green doses, the green patients were those who were able to, how long they were on 150 milligrams, yellow 100, and the red was 50 milligrams. And here we have the disease-free 2-year survival. It was pretty good at 94% with a median duration of follow-up at 2.5 years. Okay, next one. And here we have the survival by stage, about not bad, and the overall survival is excellent. So the idea was that this was actually, I need to go back and point something out. So if we look at the time to when the disease-free survival, and here we have it by years, we see that it's overall pretty good. But remember, they were taking the erlotinib for 2 years, and there is a drop-off in the disease-free survival at the 2-year mark, which is when they had completed their erlotinib therapy. So if we get to the conclusions, yes, this was feasible and in fact met the primary endpoint of greater than 86% 2 years disease-free survival. And in fact, the study is expanded to 100 patients. Only 1 patient progressed while actually receiving adjuvant erlotinib therapy. 10 patients progressed more than 6 months after stopping. They did do rebiopsies in 6 out of 8 of these patients. They did not find a mechanism for TKI resistance. 5 evaluable patients were sensitive to retreatment with erlotinib after they had progressed. Taken together, this does seem to suggest that erlotinib has at least a cytostatic effect on micrometastatic disease, but may not be helping our cure rates in this patient population. So there's another adjuvant study looking at erlotinib that is a randomized study that is still out there. It is not just in the mutant population, but is an enriched population of patients who have EGFR positivity by FISH or immunohistochemically positive. 945 patients who either do or do not get chemotherapy are randomized to placebo or erlotinib for a total of 2 years, and it's a 2-to-1 randomization. This study completed enrollment in 2010. This does harken back to the BR19 study, which was a similar design study, although done before adjuvant chemotherapy was routinely done. Patients were randomized to placebo for 2 years or gefitinib for 2 years. It was modified to allow for adjuvant chemotherapy. And in this study, unfortunately, which was closed early, the hazard ratio actually trended against gefitinib in the adjuvant setting, not just in all comers, but if you look just at the EGFR mutation patients, which was a small part of the population, the hazard ratio also trended more favorably for patients who were in the observation arm. So just to quickly go over vaccines or another adjuvant strategy. To have a vaccine be effective, you need to direct it at an antigen that is expressed ideally by the cancer but not by normal cells. One such antigen is the MAGE A3 antigen, the melanoma antigen family A3. Tumor-specific, not on normal cells, and expressed in 35 to 50% of all lung cancers, seems to be associated with a poor prognosis. So there was a randomized phase 2 study in patients with resected 1B or 2 disease, 2-to-1 randomization. Vaccination was started 6 weeks after surgery, 5 vaccinations at 3-week intervals, followed by 8 vaccinations every 3 months. In this study, other anti-cancer adjuvant therapy was not allowed. 182 patients in this randomized phase 2. Treatments were well tolerated. There was a total of 1,214 vaccines given, just some mild local and systemic reactions in less than 48 hours. There were 3 grade 3 events possibly related to treatment, leading to withdrawal for 2 patients. And here was the very promising phase 2 results. This was not powered to detect an overall survival or disease-free survival benefit, but nevertheless, the trend was in favor for patients getting the vaccine for disease-free survival and overall survival. There were also immune responses seen in patients getting the vaccine, both in antibody response and T-cell response. And here we have the the disease-free survival curve for patients getting the vaccine versus those who did not. And this has led to the design of the MAGRET study, which is a randomized phase 3 study that does allow for chemotherapy in patients who are eligible and who want chemotherapy, 2,270 patients. Following the chemotherapy or in patients who do not get it immediately, they're randomized to either the vaccine or placebo. And we also have open at our institution the PEARL study, which is the next generation using a different antigen. This uses the PRAME antigen, or the preferentially expressed antigen of melanoma immunotherapy. This is another randomized phase 2 study that is looking at 220 patients with a primary endpoint of disease-free survival. I just want to close quickly on the question of adjuvant radiation therapy after resection of non-small cell lung cancer. The PORT meta-analysis was published in 1998. This was a meta-analysis of individual data from 9 randomized studies involving more than 2,000 patients. Indeed, patients who got radiation after surgery, they had better local control, but if anything, the hazard ratio favored those patients who were on observation versus those who got radiation. The patients getting radiation had a survival decrement of 7% at 2 years. This increased risk for adjuvant radiation was seen mostly in the early stage patients, stage 1 or 2 versus the stage 3 patients. And here we have the survival curves from the PORT meta-analysis. If you look at the patients with N2 disease, however, there was no increased risk for the patients with N2 disease or stage 3A disease, and that just points out the patients with the least to gain have the most to lose from toxicity of radiation therapy. There are many, many, many criticisms of this meta-analysis. It's an old study. It used variable and unspecified staging, variable and unspecified interval between resection and radiation, inadequate radiation with suboptimal doses, large fields, poor treatment planning, outmoded techniques. Why would we include no negative patients? 2 of the studies were unpublished, and the follow-up was short. Mitch McTay actually did a review, so the theory being that radiation actually causes death from intercurrent illness, and using more modern techniques of more recent series, Mitch McTay looked at 202 patients who got radiation postoperative for stage 2 or stage 3 disease, and he found that the actuarial risk of death from intercurrent disease really was not any different from what you would expect historically from this patient population. So it seems that more modern radiation techniques are not increasing the risk of death in this patient population. The ANITA study was one of the studies on the LACE meta-analysis that I showed you earlier that was looking at adjuvant chemotherapy or observation for completely resected patients, but also this had a pre-specified analysis of whether or not patients got radiation. 33% of the patients in observation arm versus 22% on the chemo arm got postoperative radiation. And if you look at all comers, the patients who did the best were those patients who got chemo alone. The patients who got either radiation alone or chemotherapy and radiation after surgery did do better than those patients who got no adjuvant therapy. But if we break it down and look just at those patients who had N2 positive disease, the best outcome was seen in those patients who got both chemotherapy and radiation with a 47-month median survival. Those who got chemo alone had a 24-month median survival, radiation alone 23 months, and they all did better than the patients who got no adjuvant therapy for their N2 disease. and here are the survival curves for that. N2 positive patients, and these are the ones who got both chemotherapy and radiation. If you look at this SEER database for patients with N2 disease, there is a statistically significant advantage for patients who get postoperative radiation versus those who do not get any radiation. So of course, none of these are prospectively designed randomized studies, and that has come along in the LungArt study, which is ongoing. Patients with completely resected N2 disease are randomly assigned following surgery to either radiation or no radiation. They can get chemotherapy, but they don't have to. Anticipated sample size will be 700 patients, and hopefully this will finally answer the question about whether these patients should be getting postoperative radiation. So just to sum up the controversies when we're talking about adjuvant therapy for patients with resected non-small cell, which regimens, cisplatin versus carboplatin. I feel strongly that if patients are cisplatin eligible, that's what they should be getting, and it's reasonable to combine that with many different agents. Of course, you would not want to use pemetrexed in the squamous patient population. I think carboplatin-based regimens are reasonable if a patient is not a cisplatin candidate because there was a disease-free survival advantage seen in the CLGB study. What about those stage 1B patients? Well, I do think it's worthy to consider chemotherapy in those patients with tumors over 4 centimeters. Predictive or prognostic biomarkers, studies are ongoing, but really none of these are ready for prime time and should not be used for routine recommendations. And then postoperative radiation, definitely worth considering if patients have N2 disease at the time of surgery.